Well-Being class. This is the lecture on well child and adolescent assessments and health promotion. Part of what we do in primary care is probably about 25% of what we do in primary care is health supervision or well child checks, whatever you want to call it. We used to call them well child checks. Health supervision is now the more proper term, but in primary care we are providing comprehensive health care, and it's from the same provider, hopefully, over a long period of time. So you've got pediatricians who provide care to our younger generations, as well as pediatric nurse practitioners. You have family nurse practitioners, family physicians, and even internists in acute care at some point may be responsible for adolescents or infants or children. What our goal in primary care for health promotion is to actively promote physical, emotional, mental, and social well-being of children, adolescents, and their families. We're going to talk a lot about bright futures in a minute, but that's a quote from them. In an ill child, in a child that's not well, we're looking at the disease process, and that's how we determine the diagnosis. But in health promotion, we're looking at health promotion and prevention types of interventions. And just briefly to talk a little bit about some of the beliefs we have concerning child development. Generally, most children we meet are going to be healthy. For the most part, there are, of course, exceptions to the rule. We know that there are all individual differences among children, and these will be varied in their developmental processes. They may develop quickly or slowly, and that's one thing we want to always reassure our families, that each individual child is their own being, and they will develop as is their goal in life. So we don't want them to worry too much about it. Of course, part of our job is to observe for those developmental delays. Children and families all have the capacity to learn and grow. We want to always include mental health care in our developmental and in our health promotion or supervision visits, and always look at anticipatory guidance. We're going to talk about that. That is a huge part of your well child visits. It's important to think of the significant adults in a child's life, and we are treating the family, not just the child. So who is the child's family? That's what you've got to find out. Who's the person that brings the child into you? Who's the primary caregiver? And in today's world, most children are from non-traditional households. So you may have a grandmother bring the child in, you may have a grandfather, you may have a significant other. It's very important to assess who the child's family is. And remember that in pediatrics, the family is also your patient. Families are really responsible for teaching health behaviors or the lack of health behaviors. They're the ones that teach the child how to brush their teeth first and how to wash their hands, hopefully. And so we really need to establish good partnerships with those families. I like this clinical pearl. It's from Coyer, your textbook. And we talk about well child exams and what all we need to accomplish, but it's always important that you remember to think about what the parents are wanting. The parents want someone who will take time and listen to what they have to say, listen to their concerns, and care about their child. And you get a lot done with that. So for components of a well child visit, first you want to establish that trusting relationship with the parents and the child. You want to look at the history, ask the history, the good history of the child's medical history. Always include the birth history, especially in children 2 years and under. You want to ask about the type of birth, how long the labor was, were there any complications. Ask about prenatal care and their pregnancy also. Any history of illness, allergies, any medications, and always, always check on their current immunization. What's their immunization status? We're going to talk about family history in our next class time, so I'm not going to go in great detail, but I hope that all of you will learn how to do a genogram, pedigree, an echo map. They'll be very helpful to you in your primary care practice. And growth and development, we want to ask questions about their nutrition, about sleep, about their skills in motor skills, fine motor skills, language skills. Are they social? Are they personal? And what type of school and daycare situations are they? In addition to those, we're going to be doing screenings, looking at growth measurements. We may, certain visits, we may do hematocrits. We may do vision screenings, hearing screenings, lead screenings. We want to always review our systems, do a complete head-to-toe physical exam on all your well child visits. Diagnoses may be just a well child or normal exam, and then anticipatory guidance and any referrals that develop. Some techniques to achieve cooperation in your patients. With the pediatric population, you have to make adjustments. Sometimes you get out of order in your assessment data because the child's sleeping when you first walk in. Great time to listen to their heart and their lung sounds while they're sleeping, because as soon as you start messing with them, they'll be crying and you might not get as accurate. So always be flexible. With a newborn, you can use your finger, a gloved finger, or a pacifier to help them suck and maybe relax. Use a soothing tone of voice. Newborns and infants are fairly easy to examine, although they may cry. Try not to separate any of your pediatric patients from their parents. That causes a lot of anxiety, both for the parents and for the child. So let the parents help, let the parents hold the child. With toddlers, you can use more distraction. Need to explain to the toddler in their terms what you're going to do, what kind of equipment you're using. Allow them to explore. I always like to let my little patients listen to their own heart. Even at toddlers, they can do that. And once again, don't separate the child. Let the child sit in the parent's lap. Preschoolers, they may want to sit on the parent's lap, or they may be fine with sitting up on the exam table. Just depends on the child. They are very private. They are very modest. They've been taught not to let people look. So part of the things that you have to do is talk to them about that. As a healthcare provider, it's okay for you to check their genitals, but not anyone else. Allow them choices if you can. Don't allow choices if there really aren't any. I love when my students say, "May I look in your ears?" And the child says, "No." And I said, "Well, what are you going to do now?" Because you do need to look in their ears. You can use games. I know looking in children's ears, it's always fun to say, "Well, I'm looking for some potatoes in your ears," or "Do you have any Ninja Turtles?" My kids still remember what their pediatrician said to them when he was examining them. Give feedback and compliment the child on their cooperation. That will make it easier the next time. School age, again, you want to ask simple questions. If they're eager to participate, expand the questions. If not, you can talk to the parents. You always want to start out, some school ages, kids are very precocious. They want to be part of it, and some of them are shy. So just play it by ear as far as that. Teach the children as you go along. That's really important. You can teach a lot about the body as you do this, and demonstrate. With adolescents, I always start with the parents in the room at the same time as the adolescent. But at some point, I want to separate them. So it may be when I start the physical exam, I'll ask the mother or the father to leave the room, because at some point you need to talk to that adolescent privately. There's questions that they might not feel comfortable answering in front of their parents. Always assure them that you'll maintain their privacy as much as you can. You'll maintain their confidentiality unless they're going. I always tell my patients, unless they're going to be harmful to themselves or to others. So that gives me an out if I hear something that I need to report. Always remain objective. You're not those adolescents' parents, so you need to remain objective and remain accepting so that they'll share with you. So those are just some techniques of how to approach your exams and your visits with these health supervision. Now, especially for the age-specific, it's recommended by the American Academy of Pediatricians that we have well child checks sometime during the first week, and then 2 months, 4 months, 6 months, 9 months, 12 months, 15, and 18, and then pretty much yearly to age 12. And then it gets a little confusing. Actually, if I had my druthers, I would extend that all the way to age 18 because I feel like the adolescence is a time of a lot of growth, a lot of changes in their bodies and in their lives. And I would like to touch base with them yearly, but it's really difficult to get adolescents in except for sports physicals. If they play sports, they're going to have to come in, so that's a great time to continue with these exams. At least once during the early, middle, and late adolescent periods is important to see your patients. And each time they come in, you want to do an interim history update. You don't have to go back up through the whole history. Just find out what's happened in the last year. Age-specific, almost all your visits, you're going to do a height and weight. We'll talk a little bit more about this. Head circumference from newborn to 2 years old. Blood pressure, we do it at newborn age and then from age 2 through the adolescence. Your textbook says vision and hearing at all exams. I'm going to show you another chart that may have a little bit of different information on that. And then, of course, development and behavioral assessment at all exams. And these would be age-specific. A physical exam head to toe at all visits, we talked about that. And these are just some other types of screenings that we may do. We should do it at those time periods that are listed. The hematocrit and hemoglobin is important. We want to do it at least once between the first and second months. But then again, at 15 months to 5 years, does anyone know why we want to do? Usually around 18 months, we recheck their hematocrit and hemoglobin. Does anybody know why? Well, because at a year is usually when they wean off of formula or off the breast milk and are going on on cow's milk. And so oftentimes we'll see an iron deficiency anemia. Also, toddlers from 18 months to 2-year-olds are picky eaters. So we may find that they get a little anemic during those time periods. So sometime between 15 months and 5 years, but I would do it closer to the 2-year mark, just to see how they're doing on the cow's milk. We also need to check lead levels, and I'll talk about that. This is only done at children that are at risk and have symptoms. Sickle cell, again, if there's at risk, and then we always want to include anticipatory guidance. We'll talk a little bit more about that. Bright Futures is a really great website for you to go. In fact, there's a kit and a guidebook that you can download, and it's put out by the American Academy of Pediatrics, and it gives us all kinds of information for all kinds of patients. But this was the preventative pediatric health care I just wanted to show you. You can download this from that website, and it talks through infancy, what you need to include in each visit at each age. And they go ahead and run out their adolescents yearly as well. So I was going to look at the vision. I know it's on there somewhere. Yeah, vision. They have it pretty much every visit, age specific. Okay, so I have that another chart on that too. But just wanted you to be familiar. This would be something you could keep on your wall or on your bulletin board and know what you need to do at each visit. Immunizations are huge. These websites will show you where the schedules are. Every year the CDC comes out with a new schedule of adolescent and childhood immunization schedules. You also need to download the vaccine information sheets. It's required by law. Everyone the parents be given these information sheets, and you can download those. That's a very good question. If a parent objects, and I have had, in fact, I've had good friends that have refused to have immunization, and that is their right. I try very hard to explain why I think, and I do believe in immunizations. Well, first you should probably find out why they have a problem with it or what is their concern. If you can address the concern, I would send them home with information on pros and cons, and there's lots of good information out there on pros and cons. A lot of patients have heard, or parents have heard about MMR, and they think there's a connection between that and autism. That is has been proven false, so I would give them some information on that. But the bottom line is it is the parent's choice. I would explain that going to school is going to be a problem. They have to, always battle that. But as with anything, you've got to provide the best information you have, make your recommendations, and hope that they will listen. There are catch-up schedules, so if they want to wait a while, think about it, read the information you give them. Perhaps you can make an appointment for them to come back and talk about it in a month or so after they've read and thought about it. So I wouldn't give up, certainly. And each visit I would go through the same thing again. But I have had patients that are very adamant that they do not want their patients to be, or their children to be immunized. So just quickly about documentation for the health supervision visits. There's 3 different types. There's a SOAP documentation. There's a GAPS, called GAPS model. I'm just going to briefly go over both of those. And then Bright Future has their own. Whatever way you document, you want to just get that in your mind. Always go through your checklist. Be sure you hit everything in the order. If you use the SOAP, you're going to use S as subjective. You're going to ask open-ended questions. You want to find out what are the concerns that the child or the parent have. Look at developmental surveillance. You want to ask them, are they doing this? Can he catch a ball? Can he hop on one foot? Where should that child be? And ask them if they're doing that. Ask about all the subjective things in their lives, depending on their age. Safety is huge. You always want to ask, do they wear seatbelts? Do they wear bike helmets when they ride bikes? Objective is your physical exam, which would include your measurements, vision, hearing screenings, and any other screenings that needed to be done at that visit. A is for assessment. That's your well child exam, looking at development of physical, mental, and emotional. And then the P is plan. That's the anticipatory guidance and immunizations. This is for a well child exam. Of course, it would be different if it's an illness visit. The GAPS model was originally started by the American Medical Association for adolescents, but it can be modified for any age group. And G is gather information, get your history, which you always start with, assess their strengths, and as you're doing your physical, your screening, your measurements, you're asking, are there any abnormalities? If you don't have any abnormalities, you go on to your health promotion activities. If there are possible abnormalities, you want to go to step 2, which is assess further, and that's where you would go further into your screenings. What do those results from those screenings indicate? Then you have your P, which is problem identification, which is probably normal, uncertain, or abnormal. And S is solutions. What are you going to do about those problems you've identified, or are there no problems? If there's no problems, you're going to reassure the parents and the child and move forward to health promotion activities. If it's uncertain, you want to have a follow-up, so you make arrangements for that. And if there is abnormalities, it's possible you may be referring to a specialist. So that model's kind of good because it gets you into that secondary prevention piece. Bright Futures uses both of those models, but it goes on a strength-based approach, looking at priorities. Context is just looking at what age is the child, what is their status, their history. Priorities, first you want to always address the concerns or what is the top priority of the parents. But then for each one of these, and I'll post a PowerPoint presentation that Bright Futures does that identifies each of the 5 priorities for each visit. It's very handy. I didn't want to go through it because you can read it, but it would be something to keep in your on your computer that you can go back and say, yes, it's a 2-month visit. These are the 5 priorities I need to hit. And these experts on Bright Futures panel have identified the 5 priorities for each of those visits. So that's really helpful. Because the reason we do that, the reason they have done that is we can't address everything in every visit. We don't have enough time. So they picked the 5 top priorities for that age group of what you need to be sure and touch on during that visit. Hopefully over the time we'll continue. Health supervision, again, the history. You want to observe the parent-child interaction. Is there any issues going on between the parent and the child? And also looking at developmental surveillance. Again, your physical exam, screenings, immunization, and anticipatory guidance. Anticipatory guidance is information for you as a healthcare provider. It also looks at those priority questions, and it gives some information to the child and the parent. Anticipatory guidance is helping families look ahead. What do you expect that child to be able to do? So if it's a 4-month-old visit, by the time they come in for their 6-month visit, we would expect them to be sitting up, putting things in their mouth, whatever developmental stage you would expect. Not to worry of them if they're not doing it, but to prepare them. Here's what you can do. Also, anticipatory guidance, as in it's their year visit. They haven't started walking yet, but they're going to very quickly. Now's the time to talk to the parents about safety, about what kind of safety things, child-proofing their home. So you would always make that significant for the visit and the age. I think I'll stop there. Where am I right now? You were looking at your watch, am I? Okay. The rest of these slides talk about the different parts of the physical exam that you're looking at, and they're just here really for your benefit. APGAR scoring, of course, would be at birth, so you may not be involved with APGAR score, but it's always nice to know what it means. If the mother comes in with her 1-week-old baby and says he had an APGAR of 9.9, then you know that that baby had a really good start in life. And if he had an APGAR of 3 or 4, you would have some concerns. You would probably already know about that. So learn the APGAR scoring would be important. The measurements, what I've included here is it's important with up to 2 years to measure length, not height, because children have a hard time standing straight. You want to mark them using a measuring board, or mark the top of the head with a pencil and the bottom of the heel and measure the marks between the 2 marks. Make sure you get real accurate measurements. With weight, if they're less than 2 years old, you want them naked, and they don't like that, but they get very cold on those scales, but that's the best way to weigh them, because again, we want it to be very accurate. We want to measure how they're progressing. 2 years old, they can stand in gowns on the scale. We also do the occipital frontal circumference until about 2 years old. Some books will say 18 months old. I go ahead and do it at the 2-year-old visit as well. And then BMI, if you're going to assess BMI in kids, be sure you use the chart that are indicated for kids. They don't use the adult chart. And this just gives you what is normal, average growth pattern for all ages. Again, some kids grow faster, some kids grow slower. It's important to know that girls will have a growth spurt at age 9.5. Boys will have a growth spurt at 10.5. And another growth spurt in adolescence. This is weight. So by 3 to 4 months, you would expect your infants to double their birth weight, and by 12 months, they should triple their birth weight, give or take a little bit. By 2 years, they will probably have quadrupled their birth weight. And we use the growth charts from the CDC. Most places still use these growth charts. These are age and gender specific. You can update them each visit, as well as when they come in for sick visits. And I've just got some examples here. You can pull these off of the CDC website. And I want just to be sure you know how to properly graph children's growth on these, because it can get a little confusing. As you can see, there's boys birth to 36 months and 2 to 20 years, and girls are the same, blue and pink. How convenient. When you are interpreting the growth chart, you want to plot the measurement accurately. You find the horizontal axis is the age, vertical axis would be the measurement. Where those 2 points intersect is where you put your dot. and it's very hard to see on here, but these lines will give us the percentile. So 95 percentile, 90 percentile, 75, 50, 25, 10, 5. You want to see where the mark falls in there. Now, oops. Okay, so what it means is if an 18-month-old weighs 28 pounds, he is on the 75 percentile for that weight. That means that 25% of American babies, 18 months old, boys, are heavier than that child, and 75% are lighter. That's what that percentile means. So you would want to explain that to the parents. What we're looking at is the pattern of growth. It's okay if they're in the 5 percentile as long as they're growing and staying in that 5 percentile as they progress. If they're bouncing up, or more disturbingly, if they're dropping, then there's concern about their growth. So we don't want them falling off the curve, but we're not so concerned if they're small children that they're at the 5 percentile. That's okay, as long as they stay in that 5 percentile and they don't drop off. If they're at the 90 percentile and they stay at the 90 percentile, that's okay. Now with childhood obesity, we've got to kind of watch and be concerned a little bit with going higher than the 95 percentile. Vital signs I'm not going to go over specifically, you know these, but remember in a child you take a tympanic or an axillary temp. Rectal is most accurate for your infants. Apical pulses and respirations for a full minute, because in the younger children, those tend to be a little irregular. Be sure you use the right size blood pressure cuff and a stethoscope with the pediatric diaphragm so that you've got the right tools. Dental screening, the American Academy recommends the first dental visit at age 3. They also recommend that parents brush their children's teeth till about age 3, or age 5 actually. At age 3, they're not really able, they should be practicing brushing their teeth, but the parents need to follow up afterwards. Also remind your parents to just use a pea-sized bit of toothpaste, because children don't spit well, they tend to swallow. So you don't want to use a lot of toothpaste. In your textbook that gives you timing of when you could expect temporary and permanent teeth loss. Vision, again, your book says to examine vision at each visit. This would have to be age appropriate, because newborns do not accommodate. This gives you a quick referral of what you want to check at each age. And about toddler, you can use for visual acuity, you can use the little pictures where they have a house and umbrella. By preschool, they should be able to give you the direction the E is going, or use the picture. Newborns are checked, their hearing is tested. All newborns, their hearing is tested prior to discharge from the hospital. We need to look at the whisper test, because there's really no other way to do that. And then when they reach school age, that's when we start audiometry exams. If you have a hearing deficit that you suspect, they need to be evaluated sooner than school age. So parents need to be aware to watch it. I also reassure all my pre-adolescent parents that they will think that their child has become deaf because they don't pay attention, but it's probably not a true hearing loss. It's just not paying attention. Some of the developmental milestones we want to look for, and I've got another PowerPoint that I'll post that goes through specifically what types of developmental stages you would expect at what age. I'll post that for you to look at it as well, but we don't need to go over it per se. The Denver Developmental 2 test is a great screening tool. It comes in a kit. You can use it to detect developmental delays in children from birth to age 6. If they were premature, you need to know that, because that will affect what age you would expect these developmental prior to 2. By 2, they should have caught up even if they were born premature, but not always. It's not a diagnostic test and it's not an IQ test, but it kind of gives us a screening, an idea of where the child is in personal social skills, fine motor, language, and gross motor skills. Ego development, you want to screen at each well child visit. Pretty much most people use the Erickson stages, trust versus mistrust, and those are also in your book. I love those little babies. Cognitive development, you want to also screen. A lot of people use the Piaget's stages of cognitive development just kind of as a map, and again, you can see that in your book, and also you'll be looking those up for your papers, those of you who have children, to do for your wellness protocols. Nutritional assessment, you want to always assess to see if there's proper nutrition, are they growing well, and how is their nutrition. If you see problems, you want to refer to a nutritionist. These are different components of the nutritional screening that you want to look at. Most important would be the growth history, any physical signs of malnutrition, as well as allergies. And again, allergies can be huge depending on the age. Preschool, school age, you may start seeing some food allergies as they're getting more and more in their diet. The U.S. Public Health Service recommends generally that we encourage breastfeeding. I encourage my moms to breastfeed as long as they will and can. I love it when my parents can breastfeed up to a year. That's a great start for those babies. But any breastfeeding is healthy, any bit that they can do. Introduce solid foods at 4 to 6 months. Encourage iron-rich foods. Again, we avoid cow's milk before 1 year old. I don't like parents to limit fat until after 2 years old. The child needs that fat in their diet. Avoid honey in the first year. Vitamin supplements really aren't necessary if they're getting a well-balanced diet, other than possibly an iron supplement for those toddlers. But you would want to assess their hematocrit and hemoglobin first. And then children greater than 6 months, they may need the fluoride supplements if they're not getting it in their fluids. Elimination, we do a routine urinalysis at 5 years, 12 years, at college when they go to their college physical, and then sports physical. Again, elimination, one of your developmental tasks would be looking at and asking about toilet training. And I could spend a whole lecture on toilet training, but I won't. Patience is a good thing. Sleep and rest, it's very important that we assess this. I worry a lot of kids do not get enough sleep. They don't get enough rest. Even my daughter with the 3-month-old says, I can't get him to nap. You know, they still need lots and lots of sleep. Adolescents, they're the group that I worry the most about. They just don't get enough sleep. So be sure that the parents are aware that how much sleep is normal, and if they need to provide more rest time for the child, they should. This is talking about the screening for the hematocrit. We already talked about that. These are just giving you normal values. Lead levels at 12 months and 2 years. Well child exam, and anytime there is an unexplained change in growth, we do those routinely. If they're at risk, the type of children that would be at risk is anyone who's living in houses built before 1950 or before 1978 with ongoing renovations, because 1978 was when they took the lead out of the paint that we use in houses. So anyone that has playmates or siblings that have had lead poisoning needs to be screened, as well as anyone living in a zip code with 27% or more housing built before 1950. So a lot of young families are moving into homes and renovating these, and we would want to double check on the lead levels. Symptoms of lead poisoning, a lot of us don't know, so just be aware that if the child develops lethargy, fatigue, irritability, the concern is long-term neurological problems that may not be reversible. So we don't routinely screen except at 12 months unless there's risk factors. I'm getting close to the end. I just want to mention about sexual development with your older kids, school age and adolescence. We want to always look at the Tanner staging, and that gives us it rates each secondary sexual characteristic and gives us their sexual maturation rating. So you may have a girl that's at a Tanner stage 1 for breast development and a Tanner stage 2 for hair development, pubic hair development. That would give a sexual maturation rate of 1.5. Again, this is highly individualized. Children develop secondary sexual characteristics at their own individual rate. These quickly just go through the different stages for female, breast and pubic, and for male, genitals and pubic hair. And this is a diagram of what you're looking at. You'd always want to note in your documentation what Tanner stage or your young school age and adolescence at. This gives you the approximate age of sexual maturity, which is a wide variance. If a girl is past, I think it's age 16, or I believe it's 16, if they haven't started their menarche by 16, then we need to further evaluate. So you can see that I've seen girls as young as 8 years old and go until they're 16. So it's a wide range of sexual maturity. I added these last two slides just to remind you, because I understand that we're having a little confusion on what problem-oriented charting is. So always remember, when you have a pediatric patient with a problem coming in for an acute visit, these are your levels of charting: the chief complaint, history of present illness, past medical history, family history, psychosocial history, surgical history, review of systems, the physical exam, assessment and diagnosis and plan. You want to include all of these pieces in your charting. And this just goes through the SOAP notes for problem-oriented and where each one of those pieces fit. Under S is a large portion of that. O is your physical exam and diagnostic test, your lab test, anything you're doing to get that objective data. And A, assessment of diagnosis, P, plan. And that's the end of my lecture. These are great references. I highly recommend that you go to the American Academy of Pediatrics. They have wonderful resources for you, as well as Bright Futures. You can download the entire preventive services guide. They have lots of free things that you can get from them.